is it not true that if you are anxious or depressed, that amplifies the pain signal? And therefore, is it not a useful approach to treat anxiety and depression early in the treatment of pain? Because if you can reduce the anxiety and depression, you may tune down the pain signal, and you may do so in a way that interferes less with the biology and quality of life than heavy-duty pain medication.
I would say amen to that. And a lot of the antidepressants, the SNRIs, actually have anti-pain mechanisms of their own. So you may be killing two crabs with one stone. So anxiety and depression, we screen for. One of my friends, Harvey Chochinov, who's a psychiatrist in Winnipeg, Manitoba, had 169 patients hospitalized with cancer in their hospital. And he did the Beck Depression Inventory 12-question test. He did a thematic apperception test where you look at the picture and then describe. And then he had one of his fellows or residents do a 45-minute trained psychiatric interview. And then he asked them, "Are you depressed?" Or since it's Canadian, "Are you depressed, eh?" And guess which instrument had 100% sensitivity and specificity for detecting clinical depression? It was, "Are you depressed?" Or "Are you, over the past 2 weeks, have you been depressed most of the time?" And even oncologists like me can learn how to do that and then start treatment and even make a referral to a therapist. So couldn't agree more.
And Vic Teicher says, what is the best way to do that if antidepressants aren't working?
What's the best way to relieve anxiety and depression?
I think that's what she means.
Okay. Remember that there are lots of different classes of antidepressants. And there are lots of times when a combination of antidepressants works a whole lot better. So I've had terrible depression myself a couple times during my life, once during residency, and then once again when my prostate cancer I was getting radiation therapy and they gave me drugs to drop my testosterone to zero. Not only did it, the pills reduced my lung function by 50%, so I could barely go upstairs. I got profoundly depressed because, I'm a runner. All my friends are runners. That's my social activity. I got really, really depressed. Actually hospitalized myself for six days so I wouldn't kill myself. And the psychiatrist that I saw put me on an antidepressant called mirtazapine or Remeron, and it worked a little bit. Gave me a lot of side effects. He retired. I saw another psychiatrist who's put me on Wellbutrin or bupropion. And literally within a week, my mood was lifted. I was far less anxious. I was far more productive at work. I was feeling much more myself again with essentially no side effects. And my depression got a little bit worse, so we added a little bit of olanzapine. So you can add trace amounts of secondary drugs and often salvage depression treatment. That's where you need a good psychiatrist. I don't think oncologists like me or palliative care people should be managing complicated depression. And you should pair that almost certainly with some talk therapy and exercise and getting outside for 20 minutes a day and sitting in the sun.